Good evening, Namibia, and welcome to Talk of the Nation. I'm Denver Kisting, and Tate Nanda Shipahu is my sign language interpreter this evening. Now, with 19.6 million people living with the HIV virus and 800,000 new infections, Southern and East Africa is home to the highest number of infected persons in the world. As a means of continued interventions, the region and its key stakeholders convene next week to clear a path for sustained epidemic control. Amongst planned objectives, SADC countries will map out acceleration of achievement to the fast-track targets within the 2016 UN Political Declaration for Ending AIDS by 2030 in line with the SDG targets. Joining me this evening for an analysis are Mr. Sandy Charonda, Executive Director, Namibia Network of AIDS Service Organizations. Good evening, sir, and welcome to Talk of the Nation.
Good evening, sir, and thanks for having me.
Also, Dr. Eric Dziuban, CDC Country Director. Good evening, sir, and welcome to Talk of the Nation.
Good evening, thank you.
The only lady on the panel this evening, Mrs. Annemarie Nitschke, Director Special Programs in the Ministry of Health and Social Services. Good evening, ma'am, and welcome to Talk of the Nation.
Good evening, thank you.
Last but not least, Dr. Tarshis Barihuta, the UN AIDS Country Director. Good evening, sir, and welcome to Talk of the Nation.
Good evening, thank you.
Very well. I would like us to get right into it, Mr. Charonda. Let's unpack the ranking of Southern Africa as the most affected region in the world. How did this come about? How on earth did this happen? And why do we see that this continues to be the case?
Well, thank you so much. I think one is not empirically researched, but I think one can just look at a couple of factors that could have led us to the situation that we are into. And I think my colleagues can actually add to it in terms of factual and data. But this region is a region that is endowed with a lot of resources in terms of minerals. And they, for years, has been a couple of mobility of citizens across the region. And that's one factor that people are attributing the infection to, that when it happens, it actually hit us because we had a lot of movement across the region. Over and above that, I think, is the whole issue of the epidemic actually capitalizing on certain areas, such as the lack of education around it and the lack of information that we didn't have it for some time because we were trapped and held by the whole political landscape that was so much of an oppressive landscape. If you look at the whole region, most countries got independence around 94, but at least some countries got independence earlier. But I think some of the factors are talking to the whole issue of where we are coming from in terms of our liberation struggles.
I think we'll get to the interventions that have been trying to address those factors in a bit. But I'd like to understand, Doctor, what is your take on why Southern Africa is this badly hit?
Well, we know that since the beginning of the epidemic, Southern Africa has had the highest burden of cases. Like was said, it probably has something to do with the infrastructure of the area, the movement of people, men being separated from their families for work for long periods of time, like mining, for instance. But since we knew about HIV, we've known that Southern Africa has been severely affected. So it's not surprising that it stayed that way. Because while we're trying to stop new infections, we're also trying to help people living with HIV to stay alive and healthy as long as they can. So that means that these countries will continue to have large numbers of people living with HIV for a long time. Our goal is that they are supported in all their needs and that they're able to have long, healthy lives, do all the things that other people are doing in these countries, while at the same time getting that number of new infections as low as possible. That's what we mean by epidemic control.
Mrs. Nitschke, we know that the Land of the Brave has been doing very well in this regard. But before we get there, I would like to also gauge your take on why has Southern Africa been so badly hit?
Yeah, it's true, like my colleagues have said, but we also have to recognize that, you know, despite the fact that it has been hit hard, but a lot of improvements have been made. And one can definitely see that in terms of the mortality rates, definitely there's a huge improvement because we have new technology. All the time we are embarking upon new technology, see what the world is doing and copy the best practices. That is also, of course, that we can adapt in Namibia. But one should also understand that You know, apart from the fact that Namibia, we say that there's a generalized epidemic in the southern part of the country, but there are some population group with very, very increased vulnerability. And I'm just thinking about women, I'm thinking about men having sex with men, and you can really list them. So they have increased vulnerability, so it means that the interventions that we actually apply might not always have the successful results that we intend to have.
Very well, we'll get to those interventions in a bit. Doctor, what do you make from your perspective as the country director of why this region is so badly affected?
I think what I can add is the first 2 decades, when you consider 80 up to 99, 95, when you look at the responses, those countries we are developing, they're not very strong. Of course, we're not having the tools we have now. So the epidemic, the first 20 years of the epidemic, it has been going based on those factors my colleagues were sharing. So the responses started to be strong enough, starting maybe 2002, 2005. So the responses were delayed because of lack of knowledge, lack of commodities, like the IVs were not there. But the other factor is maybe also, not only in this region, the subtype of the virus. It's called virus subtype C. The infectiosity also is very, very important.
Can you get to explain that a bit, Doctor?
You know that the virus is having also different subtypes. And the one we have called subtype C here in that region, also in Africa, is also infecting very quickly. But also the other important progress, as Anne-Marie said, when you compare now what this region have been able to achieve, even if you consider the last 7 years, we managed to reduce the infections by 30%. What is not the case if you look at the West African countries. They are under 10%. When you look at the death, because of increasing the treatment, access to treatment, we have done also well in that region. We have almost reduced the death by 42% when you look at the global report released last December. When other regions like West African countries, they are lagging behind under 10%. So despite it's a huge epidemic, the progress the last 2 decades has been important.
Very well. Can you also tell us while you're at it, why is subtype C so prevalent in the region and in Africa?
I think when you look at the different around the world, of course now it's changing because of the mobility. The virus is predominant here in Africa, but you also can find it in other regions. But that is not only the factor. I'm adding that to what my colleagues have added, and this the first 20 years we delayed our responses.
Very well.
And of course, we have also other social and cultural norms. I think we'll come on it when we will talk about the factors who really we have to unburden it. They are still also prevailing in that region.
Very well.
The issue of stigma, discrimination, the issue of laws, when sometimes the laws, the legal environment is not there for all the people, including the key population, to have access easily to the services.
Very well, Doctor. Mr. Jorana, we have a sense of the historical background of what gave rise to the level of infection in southern Africa. But in 2016, there were about 790,000 new infections, 43% of the global total. We do know that a lot of resources went towards curbing the virus and curbing the infection. Did we miss the plot at some stage?
I think the progress that has been made has been extremely encouraging. But you know, the infection is such that it has been shifting faces and changing faces. And I think where we could have perhaps missed the opportunities is in targeting our interventions properly. And one of the areas that where our interventions and currently we are looking at seriously as a country is to look at the young people, because we missed young people along the way, and the infection is rising upon young people. We also are aware that, as Doctor was mentioning, the fact that for Namibia, for instance, the first years of our independence, we didn't have interventions like PMTCT, we didn't have ARVs. So we had babies that were born negative at that time. And that alone means that currently we have a backlog because we have adolescents living with HIV. We call them adolescents living with HIV. And they could actually be making decisions of whom they go out with, or whom they partner with, whom they marry. And they might not be well informed about their status. So there is also a gap in terms of information for that group and for many other young people. Some of the young people that we have right now in the country, like Namibia, some of them don't have the information because we have been shifting our interventions to try to address what we call value for money. But at the end of the day, while we're missing certain areas like prevention, like right now, we have to capitalize on prevention. I think there's an adage that says prevention is better than cure. And I think that adage, at some point, we missed that we moved quickly to treatment and moved away from prevention. Now we have moved back to, and this is not only a Namibian case, I think it's all around the region that we had been jumping up and down because really the intervention, we are trying to avert death and to keep our people alive while we are missing on the other target of now prevention.
Speaking of information and access to information, particularly as far as the young people are concerned, is it really possible in 2019 to say that young people have a lack of information?
I beg to say that, and I think maybe it's debatable, but I think I would boldly say some young people don't have the information because at some point we had a lot of information coming out, and then we had a phase where we then started to lose out on the information. Like mass media, for instance, we lost out on that opportunity. We don't have a lot of information on radio talking about HIV, and that's because the era we are living in says right now, maybe you can target information to maybe now concentrate on buying commodities, concentrate on making sure that people have got ARVs and so forth. But that information is still necessary. So I think a bit and piece of everything should be there in the mix.
Thank you. Dr. Dziuban, what do you make of the stance that there's not sufficient information filtering down to young people?
You know, I think it's not just the lack of information, but it's also misinformation has come in. So I'll give you an example. Last year, I got in a taxi in Johannesburg, and as we're going along, we're stuck in the traffic. I'm talking to the taxi driver about HIV. He wants to know what I do. And we're talking about HIV, and at some point he says he could never be comfortable getting on HIV treatment himself because he knows you can't drink alcohol when you're on HIV treatment, and he doesn't want to give up alcohol. Well, that's actually not true. You can drink alcohol when you're on HIV treatment. Modern HIV medicines, essentially none of them cause a specific interaction with alcohol. We don't want people drinking excessively in any health condition, but this idea that I can't get on HIV medicine because then I would have to stop all alcohol, that's not true. But if that's a piece of misinformation that people have, and if they're sharing that in their communities to the people that they trust, then you have an entire part of this region that maybe is uninterested in HIV treatment, even if it's a good option for them. So I think it's getting the right information out, and now we're at a point where we have to combat some of that misinformation that can spread so easily.
Yeah, I think it's important to steer away from judgment, but I think we might be in trouble if one would say that I'd rather not go in treatment if that means I will have to stop drinking alcohol. That indicates, you know, the magnitude and gravity of the challenges that we're facing. Mrs. Nitschke, what do you make of where we're at in terms of filtering through information, especially to the youth? Mr. Charonda touched on it, and Dr. Eric also touched on the misinformation. What's your perspective from the Ministry of Health side?
Yeah, thank you, Denver. I think that when we introduced the combination prevention strategy in Namibia, we were looking at the prevention and as well as the treatment and care aspects of each and every individual. And we've been working with the civil society and all organizations to look at what are the packages that we actually want to make sure that each and every population group gets. And that is now in terms of making sure that looking at the levels of education and making sure that it's being shared in all different languages. And we have looked at all these issues. Unfortunately, what one can say is that during the implementation phase, we really struggled, like Mr. Charonda says. So obviously, you are going to try and prioritize what is the best now. First of all, you have to make sure that everyone that is on treatment doesn't miss a day of treatment. So that is one aspect that you are continuously monitoring very closely. Whereas in terms of producing material and to make sure that it actually reaches each and every one, it takes a little bit of time. So it has maybe been moved a little bit backward, but not that we have stopped completely. And I think that also we have gained a lot of successes in that area, because remember there are a number of programs currently supported by government, supported by other development partners. I mean, I'm just thinking about the program in the Office of the First Lady, who are specifically targeting the youth, targeting school learners. We have programs for teenagers. We talk about teen clubs, and we have expanded that in the regions. And those clubs are really, it's where we educate, and we have people from the community who are working with their peers, trying to come together under a tree, and we just provide them with the most basic information, and then of course also provide them with what they need in terms of tables and chairs, just to make sure that they continue, and this is also sustainable in the different communities. So yes, we have moved. Maybe we are not where we're supposed to be in terms of providing information, but we are still trying to move forward. And then also that if you look at the different strategies or interventions that we have started in terms of testing, for example, because we say testing is the backbone of the entire program, then we have moved far. Because we started initially with voluntary counseling and testing, where we had those standalone testing centers. And then we have moved to bring them all to the health facilities. We say each and every health facility should be able to test any person that comes. And then we introduce provider initiatives. So it means that it doesn't mean with which complaint you come to a health facility, whether it's a clinic, whether it's a health center or hospital, you need to be offered testing and also counseling.
And I need to provide consent prior to testing.
Provided consent.
Because consent is very important
yes,
also.
Definitely.
Yeah.
So, and then we also look at the community aspect. We have also started with community. Yes, some of these interventions, sometimes you are looking at the cost effectiveness against the yields, the positivity yields that you are actually getting from it. But yes, I would comfortably say that 4 in every 10 people at least know what is the HIV status.
In Namibia?
Yes, because if you look at how we have progressed in terms of the 90 targets, then definitely I am sure that, yes, the knowledge on the HIV status is good in Namibia.
Just very briefly, for those viewers not familiar with the 90 strategy, just very briefly explain to us what that means.
Yeah, 90 basically means that 90% of the population that is supposed to be tested are tested in Namibia. And from those that we have tested, 90% of them are on treatment. And from the 90% that are on treatment are virally suppressed.
Very well. Yes. Doctor, you touched on stigma and discrimination as contributing factors to where we find ourselves as far as the spread of the virus in the region is concerned. And you also, when you spoke about targeted interventions, mentioned key populations. Please unpack that for us.
Yeah, it's important to link with the prevention. Now, as she indicated, now globally we have agreed since 2017 that it's important to come with this combination prevention, to have a huge package of services, and of course targeting some population, including the young people, young girls and the young women, including the key population, but also bringing...
What do we talk about when we speak about key population?
Yeah.
Who are those people?
The key population are defined as those at risk to be left out, particularly the sex workers, the men having sex with men, the prisoners, and also some migrants also going around, as we're saying that, and they are at risk because access to services, because of this stigma at a community level, even including the health settings, will avoid them to go to have those services. So it's important to consider this dynamic, to make sure that when we deliver services, we take in consideration some specificity. We're talking about the young people, and particularly the young girls and young women. The lack of knowledge, yes, but there are also the poverty issue. When we talk about intergenerational sex, why? When you look at...
the sugar daddy phenomenon.
Yes. When you look at the problem now, is that they are infected by whom? By the men who are lagging behind in terms of testing and access to treatment. So to solve the issue, it's important now to bring the men, the boys and the men on board. Because when you look at the transmission, it will be coming from the old men to the young ones.
Just to take one slight step back, did I hear you correctly that stigma and discrimination could be perpetuated by healthcare workers too. So where a health facility is not necessarily a safe space because their stigma and discrimination could be the order of the day.
Yes, because when you look at, I think we have a report released last year. We conduct a stigma index in Namibia, what we call stigma index, to evaluate how the people stigmatize the people living with HIV. Is not only in the communities, because those health workers, they are coming from the community. They have their background, the cultural norms are the same. When you go in the education sector, you will find some teachers who are not comfortable to deliver the life skills because of their beliefs, religious beliefs, cultural norms. So it's important to consider those factors. But of course, what we do is now to make sure that they are trained, they are aware, and also they are comfortable with all those different populations.
Because the price of that is people dying. So we cannot have that. Ma'am, perhaps you can help us understand the report that you referred to in terms of how we're faring pertaining to stigma in this country, and stigma against HIV, and even key populations.
Yeah, no, definitely there's still a good degree of stigma and discrimination, but it also depends on how you look at it. Because the moment when we introduced treatment, for example, when we test and treat, it means that every person that you test positively, you have to put them on treatment. You know, we are coming a long way because it also depends in the area that you are working. So definitely we are looking at patient supporters. So the moment that you actually agree to start on treatment, then it means that there's been shared confidentiality. So it means it's not only the person who tested you, because now you involve the doctor, you involve the pharmacist, and most of the time also somebody that supports you to make sure that you don't default from treatment. So for us, we see that it's a move in the right direction. Definitely in terms of health staff and professions, what we have done in the past and we're continuously doing is to make sure that we train people. Because in most cases, it's because people feel challenged, they don't have the specific training on the specific subject, and maybe they don't know how to treat it at the end of the day. So we are making sure that throughout the country that we at least have, you know, staff at each and every facility that has been trained in the different aspects of HIV. Because it's not only the testing, you also have the treatment part, you also have the care part. So, you know, to make sure that people also, and then you bring in the aspect of discrimination and against, and on what are the challenges that they have in that specific community. In some areas it's going well, but in some areas we still have complaints that, you know, and then the Minister of Health basically looking at it and say that when we are at the health facility, you provide comprehensive services to each and every individual that comes to the clinic. So maybe sometimes there's also sort of a misunderstanding of what is it that the person wants when it comes to the clinic. Maybe already you are stigmatized by the community and you come with it predetermined, you know, identity and say, okay, I don't want to sit with those people. I want to be treated separately. Sometimes we also impose this kind of, you know, treatment at the facilities, which is unfortunately not doable. Because you are looking at a small facility in the rural area where the one nurse basically have to see all the clients, and you are queuing up in the row like every other person, and definitely look at individuals' needs and treat them accordingly.
So there are practical challenges and considerations.
Yes.
Mr. Charonda, I just want to briefly stand still at the ABC strategy that lots of resources were spent on, you know, abstinence, be faithful, and condomize. Was that a successful approach to curbing the spreading of the HIV virus?
I think, yeah, for a start at that phase when we started, it was very, very important. It was important to advocate abstinence. It was important to advocate faithfulness to one partner, one sexual partner.
No one did that.
Yeah, and I think, and that's why I'm getting to, because then that's why we ultimately had to invest more on the C. On the commodities. We had to, as a country, put a lot of resources on the commodities and making sure that people have got access. We distribute them. Under her ministry, there is a portfolio that is directly dealing with that and making sure that not only that distribution, but making sure that people understand how to use these commodities consistently. And it's very, very important. So we invested a lot of resources around that. And we did away with the D because, and I must emphasize that's very, very important because it was A, B, C, D. The D we did away with because HIV is not a death penalty. And with ARVs, you can live a normal life. You can live a productive life. You can go on and live as much as you want and do whatever you want to do. So it's very, very important that the nation must also be reminded that no one has been penalized, no one has been sentenced to die. So the D is completely not in the equation until God himself decides.
Very well. Before I give you an opportunity, Doctor, I'd just like to tell our viewers, should you want to participate in tonight's conversation, we're talking about HIV, its prevalence in the Southern African region and what we can do to curb the spread of the HIV virus. 061 291 3339. That's 061 291 3339. What are your views? Yes, Doctor, perhaps you can share your take on the ABC strategy and to what extent that did work or did not work.
I think that was introduced at a time that there were a lot less options for people living with HIV. Prevention was based on, like you said, ABC. What do we have now for prevention? Well, there's PrEP, and this is somewhere that Namibia is really showing a lot of leadership. There are countries around here that's not part of their policy. They don't use PrEP. And PrEP stands for pre-exposure prophylaxis, which is just a long way of saying taking medication when you're HIV negative to avoid becoming infected. And we are looking especially at people that we know are at the highest risk of HIV, sex workers, people with a partner who is HIV positive, but they themselves are HIV negative.
Discordant couples.
Discordant couples, yeah. Again, long fancy words that mean something really simple, that these are people who are at risk of getting HIV, and there's now medicine that they can take to prevent getting that infection. That's fantastic. We know that VMMC, Voluntary Male Medical Circumcision, reduces a man's risk of getting HIV by 60%.
One, that one.
Well, it depends on your community. Scientifically, we have guaranteed strong evidence that this is reducing HIV prevalence. And even here in Namibia, it's actually interesting. The regions that have the highest rates of circumcision have the lowest rates of new HIV infections. And I don't think that's a coincidence. We see this around other countries in Africa as well. So this is something that can be done to help prevent new infections. And then when a man is less likely to get HIV, of course his partners are less likely. So this is affecting men and women. So we have these prevention methods that we now have strong evidence for, and they go a long way in stopping new HIV infections. And I think we want to target those where they're most needed. You were talking before about, did we miss the plot? I don't know that we did. I think that just the plot has gotten a lot more clear. We've gotten a lot more focus on exactly what we need to do. So the data helps. So we know that young girls, or adolescent girls, young women, they're the most likely to get a new HIV infection. 15 to 24 years old, they're the most likely to get an infection. Whereas men from about 25 to 34 years old, they're the ones, if they are HIV infected, that are most likely to not know their diagnosis. So that helps, because that's a different intervention for the girls and women preventing a new infection versus the men trying to get them diagnosed. So we can focus our efforts better when we have that kind of data.
So it's your understanding that the plot hasn't thickened?
Yeah. It's just become a lot more clear.
Very well. Ma'am, he just touched on PrEP. Can we just maybe say who that is available to and whether it's available in state health facilities? And also just briefly talk to us about voluntary male circumcision.
Yeah, in terms of PrEP, like Dr. Dziuban said, that we have recently introduced and started to roll out. So, you know, of course, we have to start with the training. We started with the training and then also making sure that the ARVs are available. Because once you started, you cannot go back. But we have started with selected population groups first, and not just rolled it out to the general population, because you need to make sure that people understand that this cannot be misused. You know, once you started with treatment, you should be part of the record, and we want to continue to follow you up. So yes, we have the same program that we've started, combination prevention strategy in Namibia, that introduced. They are also responsible for the PrEP in country. And I can tell you, like Mr. Dziuban say, in the areas that we have piloted, you could see there was a good uptake in terms of, especially the young population. We were actually a bit surprised about the young population that has been interested to come forward, because we are looking at rape individuals, you know, a number of things that you look at before you identify the person and register the person to be ready to take the PrEP. Of course, we need to continuously do this. We need to make sure that people don't understand it wrongly and what are really the purpose that we're giving it for and in which instances. Because it's also very costly. I mean, you need to make sure that the availability of this medication are throughout the country in all facilities and not only in the city center. So we are looking forward for further rolling out, but we have recently started and we are very happy with the numbers that we've seen.
And though one would say that issues of morality should rather be dealt with in a separate sphere, one would imagine that rolling out PrEP doesn't mean that the government is advocating for reckless sexual behavior.
Definitely not.
Yeah.
Definitely not. You know, what people should understand about HIV is also that we tend to forget that HIV is transmissible. It's a sexual, you know, it is transmitted through sexual intercourse. And that on its own needs that, it means that you have to change the behavior of the person, which is not always easy. Because it means that for us who are trying to manage the program in country, you have to make sure that the information that is available for each and everyone should put the person in a position to make informed decisions about sexual behavior. And that sometimes it's where we sometimes not reach the populations that we want to reach. Because people have to understand that, yes, an outsider have to tell you how to behave when you have sexual intercourse. So that is maybe also one of the reasons why the ABC strategy were not so successful in the beginning, because it was something new that was brought into the communities, and for us to talk, young people to talk about the adult sexual behavior in the bedroom and so on. So it was a little bit strange. But like Dr. Dziuban said, we have really made good strides because we have bring on board a lot of other interventions and other messages that we bring to the communities, and making sure that we target the specific population group with the information that we thought it's going to giving us the best results at the end of the day.
Very well. Doctor, before I give you an opportunity, just a reminder to the viewers, if you do want to participate in tonight's conversation, 061 291 339, 061 291 339. Doctor, what do you make of the dawn of PrEP, particularly here in Namibia, and how it may change the landscape or not, and also voluntary male circumcision?
Yeah, I think as they said, now that we have a lot of tools available on the table. Now the information, when people have the information and they can assess themselves the risk they are in, and they can make a choice within those broader tools we have. And of course, some you have to combine them. When we talk about voluntary medical circumcision, if all the men can be circumcised using condoms.
And be on PrEP.
Some of them, based on the risk, they can be on PrEP. So you will see that it will reduce drastically the infection. And of course, testing and treatment now is part of the prevention. It's why we are advocating that if the people can really reach the first 90, the testing, so that they can continue to set the second one and the third one.
Sorry, Doctor, we've got Adolf from Otjiwarongo on the line. Good evening.
Good evening.
Yes, Adolf, we'd like to listen to your view.
Yeah, I would like to make a small contribution. Yes, what I would like to say is that there are only two factors that I can immediately think of. In terms of HIV education, I think a large majority of the population now in this year are aware of how people get infected. But now it's more on the prevention thereof and the prevalence thereof. And I think I can immediately think of two factors. One is alcohol abuse. Alcohol and sex, they don't go along because it destroys the inhibition that the person might have naturally. Now, people become promiscuous because they don't think positively, they don't think concretely, they don't rationalize about mixing sex with alcohol because they don't now immediately think about condomizing. The other is, which is more worrying to me, is the issue of I wouldn't want to call it prostitution, but I want just to call it maybe poverty, where young girls, because of factors like poverty, have to sell their bodies. And unfortunately, I have detected that some men who already know their status, that they are positive, they will now almost blackmail, should I say, the young girls. If they have unprotected sex, then they get paid more. If they use condoms, then they get paid less. Those are the two things that I think of, and they are very much disturbing. That is my small contribution.
Thank you very much for your contribution, Adolf. Doctor, seeing that you were busy, I'd like us to quickly touch on what Adolf has shared with us. One is mixing sex with alcohol, alcohol with sex. What do you make of that?
The point is what I was saying, that how you assess your risk. So abuse of alcohol will not lead to very well assess the risk you are taking.
In that moment.
In that moment. And they end up having sex without using condom. They end up maybe, if it's a regular intake, they will not go for PrEP because they are not assessing themselves correctly.
Or they are hung over the next day, they forget to take it.
Or they will forget also to take it.
Yeah.
So the problem is real, and I think also is related to other non-communicable diseases. It's, of course, other factors like alcohol abuse. We have to tackle it, not only related to HIV, but related to other issues.
Thank you, Doctor. I'd like to get back to the contribution from Ochivarongo, but France is on the line from Omaruru. Good evening, France.
Hello.
Hi, I'm doing well, thank you. How are you?
Good. Yeah, I also want just to say something here.
Yes.
I also agree with the callers that especially the young one now, they are using the sex with the alcohol. That one is very, very, very dangerous. And also other point, I think the young one, they are not open to ask their partner. They are really to be fear. Then they need to maybe educating to, they must be free to ask your partner, what's your state?
Thank you.
Other point also.
Yes.
Maybe there is, we need to come up with such a law. If someone we know that you are infected, then you infect to the other one, you must get a punch. We need to come up maybe such a law.
Very well.
All right.
It is the direction we know that legislators are taking. But ma'am, I'd just like us to get back to the previous caller. What do you make of putting yourself at risk by abusing alcohol and not being able to make healthier decisions?
Let me just start to say that, yeah.
So we're just giving Mrs. Nitschke a chance here.
Yeah, thank you, Denver. I think like Dr. Baruta said previously, definitely there's a very strong relationship between risky behavior and alcohol abuse. And as a ministry, you know, we are also looking at this comprehensively. So in the Ministry of Health and Social Services, we have the Directorate of Social Services who are looking at, I can recall that one of the programs that we worked together was the responsible drinking. It was a coalition of responsible drinking, and definitely we have tried to target all the communities throughout the country, and bringing the message home that in the first place, I mean, the misuse of alcohol is definitely not good for any health condition. But definitely the risk is increased with conditions like HIV, because you are not in a position to make an informed decision at the end of the day. And definitely, even if you know everything about prevention, but at that mind of state that you definitely don't make the decision and you just go for irresponsible behavior.
Mr. Rana, I'll give you an opportunity in a bit. There's a caller from Windhoek. Good evening.
Yeah, good evening. How are you, my brother, my sister, my mother, and everybody, the Namibian listeners over the Republic of Namibia?
Thank you, Abdul.
Yeah, actually, I just have a small contribution also. I'm listening to your show. It's very interesting and nice. My main point is that I think what you are supposed to be done in terms of circumcision, for instance, you go around the places like Katutura and other regions whereby you find many men. We have different tribes. culture, traditional, is supposed to be the main key of success of this pandemic of circumcision, whereby you speak to the elders, the traditional elders, on how to bring up a system to say, okay, we have people around us, boys and girls, who does not circumcise. So how can we try to bring awareness of circumcision in our own tribes? Sorry for that. So this is the main of the point. And then you put it in the also parliament. Parliament has to be a platform whereby they can decide to do this region's coordinative system to see how can we help the local government or local authority, especially hospitals which are next to the villages. So how can we help those people to contribute for them? So maybe some of the people cannot afford, and some of the people, they are scared. And how can we give them a confidence of going to circumcise?
Thank you, Abdul. Thank you very much. Mr. John, I was saying that you wanted to, thank you very much, wanted to address some of the earlier points. Could you just condense it and also maybe say something about Abdul's call?
I think I wanted just to say that, well, with regard to alcohol abuse, alcohol does not only impair your decisions. It does not only affect the prevention component or element of our management of the disease, it also affects the treatment component. So alcohol is really cutting across, and it's really impacting on our ability to reach our results. So I think that is a very deeper topic to discuss in terms of looking at the access of alcohol that is available and readily available. And let me move on to the vulnerability that we talked about, particularly when it's moving over to VMMC or voluntary medical male circumcision. I think we have that program that is very, very important. The doctor mentioned that there is evidence that it reduces the infection. But we must emphasize that it doesn't say that it gives you now a license to have sex without using prevention. You still need to use the condom and apply it with a condom. And I'm saying this deliberately because it sometimes we talked about messages that are coming out, and sometimes people start to think that they said if we are circumcised, you can actually go without a condom. And lastly, on the caller, I think the whole issue of circumcision, it has gone out. The ministry and civil society has gone out to promote circumcision in regions that are not circumcising. Because we have got regions that are traditionally circumcising and regions that are not circumcising. So we have even engaged people like music artists who were helping us to carry the message. Dr. Alfiku was one person that actually did and went into to do the operations himself. So I think that has been promoted very well. And regions like Zambezi and others that were not actually traditionally circumcising, people actually came and started to access the service. And I think it still continues and still something that is accessible in hospitals.
Very well. We need to unfortunately wrap up. We've run out of time, but this is not the end of this conversation. We need to continually have this conversation, and we need to have it again. Perhaps I can also, while we're with you, Mr. John, give you an opportunity, just your very brief concluding remarks.
I want to thank you for this opportunity. And I think, obviously, this is a build-up to a meeting that is coming next week, which is going to discuss the issue of sustainability and looking at what we do in terms of moving forward and achieving the targets that we set for ourselves as a country and as a region. We're talking about the whole SADC region. And so we realize that the core and the corner of it is that we need to still continue the investments. We need to still to have the resources for certain interventions that could help us achieve those results. And civil society interventions are critical, and we still want to say that we need to look at some of those areas where we are losing funding, particularly because of external donor funding. The landscape is changing and donors are pulling out. So we need to really look at how does our governments continue and plug the gap that is opening.
Thank you. Dr. Eric, your concluding remarks, please.
I hope that your viewers can be there tonight in their homes, really proud of where their country has gone in the HIV response. When the US government first arrived to partner with Namibia on HIV, over 10,000 Namibians were dying every year just from HIV. And now that number is under 4,000. If you stop and think about that for a minute, that's over 100 funerals every week of Namibians from HIV, every single week, every single year, that are completely being avoided because of what Namibia has done to help control HIV. That's a remarkable success. There's still work to be done. And your callers mentioned some of the risky behaviors, some of the reasons that we might still be seeing HIV infections. We all want it to go further than this. But Namibia has really been a leader in Africa in identifying the policies and the practices that are going to bring HIV down and eventually end this epidemic.
Thank you. Madam, I can imagine that you're a proud woman this evening, but the work is far from done. Your concluding remarks, please.
Yeah. No, I just wanted to appreciate that funding for HIV and for all health services in Namibia still remains a high priority for the government, and we really appreciate it. But to my community people, I just want to plead to them that yes, we are bringing a lot of different service delivery models to you, but this is really our way in trying to contribute to the sustainability. We want to make sure that these programs and interventions that we bring, first of all, that community definitely benefits from it, but also that they own it, so that in the years to come, if funding maybe declines further, or we might be in a situation that we don't have enough funding to have luxury, then we are happy that the community have models that they have understood, that they are owned, and that we can sustain the achievements that we have made.
So the communities need to own the prevention strategies themselves. Doctor, the final word is yours.
Thank you very much. And I think I can say that based on the result indicated for Namibia, I really want to congratulate Namibia, not only for looking at his national response, but also to bring SADC region here for next week to discuss about sustainability. And this meeting was, of course, agreed on between UNAIDS and His Excellency, the President of Namibia, saying that how Namibia can use this example to bring other countries. Our former UNAIDS Executive Director, Michel Sidibe, in February, they agreed with the President, His Excellency President Hage, that it's important to bring this conversation. And of course, you recall that the last 10 years we have been talking about global solidarity, shared responsibility, how we bring all those efforts together, but not only at national level. You can look at the cross-border issues. If Namibia is doing well and Angola and Zambia or Zimbabwe are not following, it will jeopardize those things. I think it's very, very important, and I think next week we hear more, and I think we'll have some also good practices from the country, including Namibia.
Just in one sentence, Doctor, what do we talk about when we talk about sustainability?
In one word, Namibia, for instance, have reached 90-90-90 target. How we make sure that we continue and to reach the other remaining 5% of the population who are not tested, they are on treatment, and how we make sure that all those results are sustained.
And eradicate the HIV virus.
Until we end HIV/AIDS by 2030, make sure that we reduce drastically the new infections, we reduce drastically the death.
Thank you.
And the virus will be controlled.
Thank you. So I just need a yes or no from you. Is it possible to have HIV gone by 2030? Yes or no?
For Namibia, I'm very optimistic.
Yes or no?
Yes, we're on the way.
Yes or no, ma'am? I take it it's also a yes from you.
Yes, and it can be achieved if the global solidarity remain.
Very well.
And also domestic funding
is made available
on the table.
Thank you. Thank you, Mr. Jaronda. Thank you, Dr. Dziuban. Thank you, Mrs. Nitschke. Thank you, Dr. Bariuta. And thank you for your time and your expertise and sharing and for the constructive conversation.
Thank you so much for having us.
Thank you.
There you have it, Namibia. By 2030, we could eradicate the HIV virus. That's a very big deal. So let's all do our part. That was Talk of the Nation. Goodbye.